So this is our breakdown scene, and in this scene I have the pleasure of having Mr. Frank Alfonsi in my clinic. And what I don't know yet is that he's the favorite dough thrower at Original Red Luca. My kids and I love that place. And the reason I'm telling you this is because you should always be ready to make a connection to what's going on with your patient. And in this case, I happen to know him, meaning I didn't know him personally, but I know him as a dough thrower. And it's nice. You can always create a bond, and that bond helps with the patient history. But at the beginning, I talked to Mr. Alfonsi, and he told me the beginning of a fascinating tale. What did you tell me? Where had you just come in from?
Italy.
Okay, what were you doing there?
I was getting some tomatoes for,
Right.
for the gravy for the pizzas.
Right.
Yeah.
And what did you say about your flight on the plane? Did you get to walk around?
Oh, no, I just stayed in the window seat.
Yeah, so it's fascinating because this patient didn't move, and people are people. And even though everybody knows you should get up and walk around a plane, he had some kind of issue. He didn't want to bother the other people, right?
Yeah, I just didn't want to bother the other people, and then they get mad, and then I have to say something or do something, and then I don't get to go back.
Right.
On the
And
plane.
that's because patients are human. This is a complex individual. He's not just the sum of his illness or ailment. He has issues that come to bear on this. And in this case, his own behavior caused this acute medical emergency. So once he told me that, I was already thinking, man, this guy has, and he complained of calf pain. That was his chief complaint. Calf pain and a long plane flight. You should be quickly thinking DVT, because that's what those two things usually lead to. A long plane flight and calf pain could be DVT. But now I want to ask a little more. So the next thing I did was say, tell me more about the story. And the story fit very well. So the pain was sudden, it came on, and overnight it didn't get better, right?
No.
And you tried all kinds of things.
Yeah.
What did you try?
I tried ibuprofen. I tried putting my leg up on pillows.
Sometimes elevating the leg will help a little, but if it's a real clot that's forming, nothing's going to help. That's a lot of pain. He described the pain as 8 out of 10. It was stabbing in quality, and it really sounded to me like the description I've heard when patients have a DVT. So I'm thinking a lot about that, but I don't want to narrow my differential so quickly. So the next thing I want to know is anything else possible. So I ask him a series of questions, and I start kind of from the top, asking if there's headaches, vision changes, and when I got to chest pain and shortness of breath, what did you say?
Yeah, I had those this morning.
You had those. So since he had both of those, I'm now concerned that this clot that's in his leg is spreading and becoming a pulmonary embolism. So this shifts everything. I want to now go a little quicker because I want to get to the physical exam and get this guy to the ER if what I think is true. Now I do know that clotting disorders, which perhaps my patient has, run in families. So I asked Mr. Alfonsi, hey, have you ever heard clot mentioned in your family?
Oh, yeah, Uncle Giuseppe had a clot. Yeah.
Right. So now I'm bringing together so many pieces of evidence. I'm solving the case. I am now pretty sure just from history that this is a DVT. The good thing is that he came here early enough. It's not yet a pulmonary embolism. He's early enough where we can check it with a Doppler, see a D-dimer, and decide if it is a DVT. And if it is, we can treat it with anticoagulation. He might have a few-day hospital stay, but these medications, the sooner they get into his bloodstream, will start to help the clot break up and the body resorb the fibrin elements, the pieces and particles of this clot, so it doesn't become a PE. So when I examined the patient, I forgot to ask during the scene about pitting edema or to check for it. So it's important to always find out if the patient who might have a clot has pitting edema because of the stasis, the vascular stasis in the lower extremity. You're likely to see if you push down on the tibia with your thumb, you'll see your thumbprint remains there for 2 or 3 seconds. If it's there for 5 seconds and it's truly a pit, that's an even worse scenario. We call that pitting edema. Now, most people with a DVT will have edema. I, in physical exam, felt warmth, and I saw erythema, and those are 2 classic signs of a DVT. In addition, I knew this patient had at least 2 of Virchow's triad. He was on the airplane for a long time not moving, and that's the stasis. He didn't have endothelial injury, but he could have a hypercoagulable state. What are hypercoagulable states? Hey, it could be cancer, it could be pregnancy, it could be smoking, it could be birth control pills, or in this case, a familial disorder like a thrombophilia. My thoughts run immediately to protein CNS deficiency, perhaps factor V Leiden, but in any event, that really makes me think we got to get this guy some quick treatment. So you see the path I took. It was based on our conversation. And in the conversation, I always want you, and this is important for the CS, to remember to respect your patient, to emote with your patient, to say, I'm sorry you're in pain, and to look for opportunities to make a connection. You get really good scores on this exam if you see those opportunities and seize them. A lot of what the CS graders are looking for is that ability for you as a physician to emote. And you saw that Mr. Alfonsi and I really had a connection. And more medicine is moving towards a partner approach and not a hierarchy. So they're going to be looking closely. If he gave me those beautiful, easy conversation starters about the pizza place, about the tomatoes, I went with it. I tried to get to know him and find out more of what was going on. And then it's easier for him to talk to me about anything. I think in this last round, did I ask you about if you're sexually active and all that?
Yeah.
Okay, I did.
Both times.
Okay, yeah, okay, good.
Yeah.
Okay, my point being is you can't just jump to something personal. Save that for the end. And it is useful because once you've established a rapport, you can ask if it's a female, you can ask about menstrual history or OBGYN history. If it's a male, you can ask about sensitive topics about the patient's sexual life. You can ask about whether they're using illicit drugs, and they'll tell you because they know you. So remember, this case was apparently simple, but there were layers of complexity. And I want you to really pay attention to the way I connected to Mr. Alfonsi. I even want to go to his pizza place.
Frank, please call me Frank.
All right.
My friends call me Frank.
Yeah, I appreciate that. I really want to go to his pizza place. And you know, it's okay to say to the patient, yeah, I know who you are. I'm so excited to meet you. You know, you don't have to be so distant or so separate. Respond, and you'll see the standardized patients on your CS exam will have certain moments where they say, you know, I like surfing. I'm a surfer. And you could say, hey, look, I see the surfers at the beach. I want to try it too. Find ways to connect. And these are really important gems. These are moments that you have to seize and take advantage of. So in this case, we used some classic logic and everything fell into place. It was a long plane trip with a possible thrombophilia and a patient who came in with what I could feel as a rope on his calf, erythema, and pain behind the calf, and also some symptomology of a potential pulmonary embolism. We got to get that patient to the ED and treat him as soon as possible. So that's how I want you to approach calf pain on your CS exam. Thanks, Frank.
Hey, no problem. Not for nothing, but should we get to the
Yeah,
emergency room?
let's get moving.
Okay.